data, the incremental increase in awareness is between 51% to 70%, and awareness and incremental increase in control is from 10% to 30%. Far more is desired, but still the impact of this awareness and control, what this impact has had on healthcare of the world, we can clearly see that in the same time span of 1970 to 2000, because there was an incremental increase in awareness and control of blood pressure because of various guidelines that were put into place, the global stroke mortality and the global ischemic heart mortality has come down dramatically. So the importance, I'm using these points to highlight the fact that treating a hypertensive individual is important for that person to reduce events which we may or may not see in the lifetime, but treating hypertensive will have a profound effect on the health of the society, and that cannot be undermined. We also know from past data of natural history in normal individuals that lower the better till 115 by 75. What is the data beyond lower than 115 by 75? We don't really know, but 115 by 75 blood pressure is better than 120 by 80, is better than 130 by 85, and so on and so forth. And we will come to this point, why we have raised this point, when we come to the management part of it. So coming to the fundamental question that whenever a hypertensive walks inside a cardiology clinic, he is aware that he has hypertension, he is seeking help. He or she may be confused about the goals of hypertension. What is the kind of, should I keep it at 140/90 as someone says, 130/80 or 115/75 as the data says? Or they may be coming to us when the hypertension becomes difficult to control. It has not been able to properly control by the primary physician and they are coming for a second opinion. They may be also concerned about hypertension being a part of the global spectrum of cardiovascular diseases, and they want a holistic cardiovascular treatment, not just the treatment of a hypertension number. That's also a valid reason why they come to us. And then, of course, there are special situations like renovascular hypertension, coarctation of aorta, obstructive sleep apnea, and a variety of causes of secondary hypertension. And of course, they may be seeking the help of an interventional cardiologist or an interventional radiologist for the treatment of, for example, the intervention treatment of advanced heart failures and resistant heart failures, like renal artery stenting, renal denervation therapies, and so on and so forth. So most of the guidelines, I would not like you to get focused on a number in terms of focusing what to do for hypertension for two reasons. Firstly, the targets have never been the holy truth. They have been changing from years and between guidelines. And if you see the guidelines between 1970s and 2020, we will not be able to identify what is a hypertension and what you should treat and how much should you treat. That is one point. So don't be too focused on the number. The other reason is that hypertension is just a spectrum of holistic treatment. So please treat the patient with hypertension and do not focus on the number and do so obsessed with the number that you forget the patient in totality. A lot of joint national committees have been coming up, and as I said, they have given different values for hypertension and diagnosis. The recent one, 2020, for the sake of just example, we can say normal blood pressure has been described as less than 130/85, office blood pressure as less than 140/90 when you are trying to control, ambulatory blood pressure, 24-hour average less than 130/80, and home BP monitoring on an average ratio of less than 135/85. Again, these are mere, guiding principles for us where to go. We know that lower the better, but how much lower we can go on treatment, we will discuss in a minute's time. The question that I want to come back to my old slide, that why should we not treat all patients to the level of 115/75? Because most of the guidelines will go as low as 130/80 and they will not go any lower. The reason is that while we do know that those individuals in the natural history who have blood pressures of 115/75 are better than 130/80. These are for natural history of patients who are not on treatment. How much can you go on the drug treatment to bring the blood pressure? You will have to have a comparative arm when you compare two strategies, and that strategies have not really shown benefit, with the one example of SPRINT trial in which a strict control of blood pressure was superior, but it has got its own fallacies. We'll come again to that point later. But generally speaking, bring the blood pressure down on medication less than 130/80 has not been shown to have an incremental effect on the cardiovascular health of an individual. Also, it adds to the cost, it adds to multiple of drugs being given, and it also adds to the cost being added to the patient. That's the problem. The third issue is that if you try to control the blood pressure too strictly, especially in elderly individuals, it will lead to hypotensive episodes in between, and of course it will lead to falls and other injuries and other complications, especially in elderly populations. So that's the reason why we know that 115 by 75 is better. We like to keep it a little loose for population-based strategies, although for individuals, we may have a strict control of blood pressure as compared to this, as was shown in the SPIN trial, like let's say a 120/80, providing these patients are regular in their follow-up, they are coming to us for regular follow-up, they are getting their blood tests done regularly, and so on and so forth. So again, I'll keep on reminding this question again. We become so obsessed when we are treating hypertension with a number that we, many a times, all of us tend to overlook the overall patient. We have to treat the patient with hypertension and not just a number, because cardiovascular diseases and the risk factors come in a consortium, and we have to reduce the overall cardiovascular health, because otherwise it's just a number that we are treating. So, given this whole fact, giving a number of less than 140 by 90 or 130 by 80, or according to SPRINT around 120 by 80, is probably trying to answer a very complex question in a very simplistic way. It works for the guidelines because the population-based strategies have to be based on that, but for individuals, we may rationalize treatment according to the class of the patient, according to the risk factor of the patient, and so many other variables that we can consider. So the first step is assess the risk of the patient, decide what is the tentative goal. Don't buy a very strict number. What is the tentative goal that will keep the patient, and then decide the best drug and drug combination. Generally speaking, the control of blood pressure needs to be a little more strict in younger individuals as compared to elderly individuals. In the elderly, a little loose control of blood pressure to around 150 by 90 is sufficient. But when the person is younger or the person is suffering from multiple comorbidities, a little strict control of blood pressure may be required. If it was just a case of numbers, that we have to bring down the number in the blood pressure, then we could have given any drug. The whole controversy was about beta blockers or which diuretics would not have come into play. So it's more than the number. We have to look at which is the drug which is, apart from controlling the blood pressure, is also controlling the cardiovascular health and decreasing the cardiovascular events, and that's why the choice of drug becomes important. And also this drug controversy about which to be given or which not to be given